Now that we have taken a bird eye view of what's happening, let's take a look closer to home. And to do so, I would like to invite Ms. Brooke Holmes. Ms. Holmes is a program administrator in the Office of Population Health Improvement with the Maryland Department of Health. She also serves as the program director for the Opioid Misuse Prevention Program to reduce misuse and inappropriate medical use of opioids, and is also the program director of the Overdose Fatality Review Program. She coordinates 4 federally funded grant programs aimed at implementing data-driven, evidence-based strategies to prevent first use, misuse, and fatalities resulting from alcohol use and other illicit and licit substances. Brooke previously worked with Montgomery County Coalition for the Homeless, where she coordinated services for formerly homeless, single adults with mental health disorders and substance misuse. Her passion has been focused on providing resources to citizens and attacking behavioral health problems prior to its onset. Please help me welcome Ms. Brooke Holmes.
Thank you very much for that introduction, and good morning, everyone. I have quite a bit of information to give you, so I'm going to try to go through it quickly. Please, if you need to stop me, just get my attention, and I will try to slow down. All right. I do not have any relevant financial relationships to disclose. The objectives for today, I would like for you to be able to recall the impact of opioid misuse in Maryland, as well as identify Maryland's response to the opioid epidemic, as well as identify Maryland's prevention efforts toward the reduction of pregnancy-associated overdose at both the state and local level. And so this is our table of contents. We're going to go through the impact, showing you some data. We're going to look at what Maryland's response actually has been, the pregnancy-associated response, as well as what's happening at the local level, again, with pregnancy-associated prevention efforts. The information that you are going to see on the slides that I'm going to present you is taken from the 2018 Unintentional Drug and Alcohol-Related Intoxication Death Report that is produced by the Vital Statistics Administration at the Maryland Department of Health. The majority of the information that they put in this report, included in this report, is taken from the Office of the Chief Medical Examiner. And Maryland law requires that the Office of the Chief Medical Examiner investigates all deaths that occur in the state that result from violence, suicide, casualty, or take place in a suspicious or unexpected or unusual manner. Okay, so what you have here is a number of opioid-related deaths that have been occurring in Maryland by substance from 2008 to 2018. Sorry, all of the graphs that I'm going to show you, the time frame is from 2007 to 2018. And so what we've seen here is that we have 89% of all intoxication deaths that have occurred in Maryland in 2018 were opioid-related. The opioid-related deaths include heroin, prescription opioids, and non-pharmaceutical fentanyl. The number of opioid-related deaths have increased by 7% from 2017 to 2018, which is slightly less than the 8% increase that happened between 2016 and 2017. And what we're seeing, as you can see on the screen, is that fentanyl and heroin are primarily responsible for the dramatic increases in these deaths. Here you have heroin-related deaths occurring in Maryland. They have decreased in 2018 as they have in 2017, and they're decreasing among all age groups and sexes. 87% of heroin-related deaths have occurred in combination with other substances, such as prescription opioids, alcohol, fentanyl, and cocaine. Here we have fentanyl-related deaths that have occurred. They're no longer isolated outbreaks. They're these fixed characteristics of the current illicit drug supply. Large increases in the number of fentanyl-related deaths have continued to drive the overall rise in opioid-related deaths. Here we have the number of deaths occurring in Maryland by selected prescription opioids. These deaths have been rising since 2013, but they declined slightly in 2017 and then declined again in 2018. And as I mentioned, fentanyl and heroin are the primary causes. So Governor Larry Hogan has these primary initiative areas that he wants to focus on, which are here on the screen: prevention, the harm reduction, the treatment, and the enforcement. On the other side of the screen, I believe that's to your right, on the other side of the screen are all of the programs that, or initiatives that the state is implementing, and those are the ones that I'm going to go through today. So first we have the Maryland Heroin and Opioid Task Force and Coordinating Council. I apologize for me jumbling up my words today. Governor Larry Hogan established these two by executive order in February of 2015. Both of these groups were established to work in tandem to support various efforts to address Maryland's heroin and opioid crisis. And it just provides an opportunity to share data and to make recommendations for policy, regulations, and legislation. Additionally, as the epidemic continued to rise, Governor Hogan came back and said, okay, we have this state of emergency, which he declared in March of 2017. And because of that, we had this 2017 Heroin and Opioid Prevention, Treatment, and Enforcement Initiative. That created the Opioid Operational Command Center, or OOCC. And their job is to build on what the council and the task force recommended, and they coordinate with partner agencies to do so. In 2017, about 30 bills were introduced to combat the opioid crisis, and many of the initiatives were put into a legislation called the Heroin and Opioid Prevention Effort and Treatment Act of 2017. You'll hear more about how that HOPE Act, as what we call it, enhanced one of the other efforts that we will be mentioning today. Okay, so we have this state-targeted response to the opioid crisis and the state opioid response grant programs. These grants are aimed to address the crisis by increasing access to treatment, reducing unmet treatment need, and reducing opioid overdose-related deaths through the provision of prevention, treatment, and recovery support services. The STR-funded Maryland Opioid Rapid Response Program is managed by our Behavioral Health Administration, which is also in the Maryland Department of Health, or BHA, and it's strategically aligned with the goals of the OOCC that I just mentioned, and was established by executive order as part of Governor Hogan's 2017 Heroin HOPE Act that I mentioned as well. We also have the SOAR grant funds this. It's the Maryland State Opioid Response. This builds on the efforts that the STR grant was designed to do, and continues to increase the capacity of local service delivery systems to provide coordinated and integrated evidence-based prevention, treatment, and recovery support efforts. This program, the Opioid Misuse Prevention Program, is run out of my office, the Office of Population Health Improvement, and is one of the programs that I directly am responsible for. This began in 2015. And the goal is really to kind of strengthen and enhance the local overdose prevention plans that had previously been established. So overall, our goals are to, of course, reduce the local contributing factors, reduce opioid misuse, reduce opioid overdoses, and then ultimately reduce overdose fatalities. And I believe one of my jurisdiction's OMPP coordinators is in the room today. These are some of the strategies that are being implemented at the local level. It's not an exhaustive list, but we have these strategies broken down into primary, secondary, and tertiary strategies. If you're not familiar, primary prevention aims to stop first use. Secondary prevention aims to reduce the impact of after first use, and then tertiary prevention aims to reduce the impact of ongoing illness and injury. We have these crisp opioid indicators dashboards. This is a service that is provided by the Public Health Services Administration within Maryland Department of Health, and it's in collaboration with the Chesapeake Regional Information Systems for Our Patient, or CRISP, and they house our Health Information Exchange. The goal of the project in general is to allow approved local and state government stakeholders access to timely aggregate statistics from these data sources in order to assist them with planning and evaluating interventions related to substance use. And so I know it's been mentioned before, the PDMP, so I'm sure you all are familiar with that. And then the overdose-related hospital encounters dashboard. We also have our Overdose Response Program. Again, I talked about the HOPE Act initially. The HOPE Act helped in streamlining ORP operations for the state. Our Overdose Response Program is our public health naloxone distribution model, and it is established in law and regulations. The provision of the HOPE Act intended to increase access to naloxone by removing the requirement of training and certification before receiving naloxone from a pharmacy under that statewide standing order. So the overdose fatality review, that's another program that's under my purview in my office. This is very similar to child fatality review and maternal mortality review, where we have these multi-agency and multidisciplinary teams that come together at the local levels to review overdose cases. They meet at least quarterly, and the purpose is to identify these missed opportunity for prevention and any gaps at the system level, work on building their relationships to cut down barriers to sharing of information or providing treatment and resources to individuals. To prevent future overdose fatalities, their families, and individuals who may experience a non-fatal overdose. We also have here our Overdose Survivors Outreach Program. This is also managed by the Behavioral Health Administration. And one of the reasons why this program was started was because we know that data indicates prior overdose as a risk, right, factor for future overdoses, and the high percentage of individuals who had visits to hospital emergency rooms prior to overdose deaths. So this funded project seeks to create better pathways to treatment by creating closer collaboration between medical facilities, local health departments, and treatment facilities. Now we'll discuss kind of the impact on pregnancy-associated overdose in Maryland. And so I brought up the Maryland Maternal Mortality Review Program, which is also established in statute. The purpose of the program, is to identify maternal death cases, review medical records and other relevant data, determine preventability of death, develop recommendations for the prevention of maternal deaths, and disseminate findings and recommendations to policymakers, healthcare providers, healthcare facilities, and the general public. The Maternal Mortality Review Committee was established by this program and is made up of volunteer healthcare and public health professionals and conducts maternal mortality case review. The committee got together and wanted to understand the factors that are involved in overdose deaths. So they review all pregnancy-associated deaths in Maryland from 2010 to 2016. And over that 7-year period, they noticed that substance use and unintentional overdose was the leading cause of death. And it accounted for 59 of the 267 pregnancy-associated deaths that occurred. This remains to be kind of the leading cause of pregnancy-associated death for the 4th consecutive year in Maryland. And out of the 59 overdose deaths, 57 of them involved opioids. Here are some recommendations that the committee came up with from their, that is written in their 2018 annual report. I'm not going to read all of them to you. I do know that you get these slides, so you'll be able to see them. But some of those things on here talk about encouraging a use of the PDMP by providers. It talks about using SBIRT more. It talks about informing substance use treatment providers about prenatal health, a lot of improving communication and collaboration between providers of prenatal care and other providers. And so, yes, there's quite a few recommendations that they have there. Additionally, and these I'll explain a little more. Additionally, the committee supports these 4 efforts here. The Perinatal Neonatal Quality Collaborative in partnership with the Maryland Patient Safety Center. This is an initiative that is related to substance use. The collaborative is an effort among all Maryland delivery hospitals to address quality improvement in obstetric and neonatal care. And this collaborative began quality improvement project to address the care of pregnant women with substance use disorder. You also have SBIRT. And with SBIRT, it's an evidence-based approach to providing early intervention and treatment to patients with problem alcohol or drug use. They are looking at training obstetric providers. Additionally, you have the resources that are made available by MedChi, which is Maryland's state medical society. They provide resources that include opioid-related educational materials and activities, including opioid alternatives and opioid prescribing guidelines and various other things. The committee also has been, one of the things that MedChi also does is they have a app. It's called I Prescribe app. I'm not sure if, I know there are some providers in the room if you're familiar with that, but it's a way for you to access the PDMP easily from your mobile device. So I wanted to make sure that I mentioned that if you were not aware. The committee also is looking at developing provider alerts to disseminate information about maternal deaths in Maryland. And one of the alerts that they're going to begin providing is to increase provider awareness of the contribution of substance use and unintentional overdose maternal mortality. Okay, and technically my last slide, Wicomico County, and my OMPP coordinator from Wicomico County is actually in the room, so she'll be here, and I'm sure she'll tell somebody about what's going on in their jurisdiction. But this is how it's being implemented at the local level. They are looking at collaborating with rehab and treatment centers to educate and provide resources to women of childbearing age. Of course, to prevent neonatal abstinence syndrome and maternal opioid dependence and relapse. And these are some of the topics that are included in the resources and education that they provide to the community. And so, thank you. I want to say that, Maryland really is, as you can see, there's a lot of information here. Again, you will be able to see all of this later. Maryland really is committed to addressing this issue from various angles. We do collaborate among the different administrations. And we, do want to increase, we've seen an increase in knowledge, perception of risk, and misuse. Thank you.
Minutes for questions.
All right. That's either a good thing or a bad thing. Just on my evaluation, though, just say I did excellent.
Well, we are very glad to hear the state's perspective and to learn not only the acronyms, which I struggle with,
I struggle with them too. There's a lot.
But we're certainly happy to see that there's so many components that the state is trying to tackle. Even the survivor network is one, which is I think a really important one, and then the collaboration with the community.
It looks like there's a question.
Okay.
I have a question in reference to that Wicomico collaborative. You itemized in the efforts that they're making. What about family planning?
Well, she's actually in the room, so she might be able to answer that question for you. Takesha Collins is our OMPP coordinator for Wicomico County.
So they're already working with a population that are deemed at risk. And so if they're working with a provider that's treating the women, is there any discussion or collaboration with the local health department to discuss family planning so that they may not have MG1 pregnancy?
Well, yes, the family planning already hangs out condoms and teach about safe use among that population. But like you said, it's new under the plan. the fact of them becoming pregnant. Before becoming pregnant, their statistics don't really show basically what efforts, but I do know they have free clinics, they have condoms, they teach about birth control, but that's under the family planning. They already do their regular, they start at high school age on up, because there is a directive there, that there is a program there that talks to young women about starting sex condoms and safe use, and they're going to get their regular checkup so they can sugar.
Well, I guess I misunderstood the collaborative then, because I'm thinking about, especially those women that are in the postpartum period. We know that there is a reduced rate in women who actually follow up for postpartum appointments. And so access to an understanding of methods for family planning that really could be impactful if you're working directly with providers, because they're more than likely to go back for additional MAT treatment versus a postpartum appointment.
I'm going to address that with a presentation. So,
I get where you're coming from. What we're finding is, when I did my focus groups, they're basically saying that's not the aspect. A lot of the focus group indicated that they felt like they don't have any support after the fact with, I guess, coping skills and parenting skills. We're not finding that they're not going to their appointments afterwards. It's basically the support thereafter, and they're being discriminated, stigmatized against about having children or having more than one child. So when you talk about family planning, you don't want to, you want to teach the public period about family planning, but you don't want to go to a direct population, because that starts to stigmatize and become judgmental that we should target them to not have kids, because it's still their right to have children if they like to. Just like a person, she said, with diabetes or heart disease or anything else, it's still a disease, and we still don't want to target them and say they'll be unfit parents because they struggle with this disease. So kind of that approach is kind of risky if you're just targeting one population. So overall, the family planning just targets the population overall. It's not a high-risk population, because you don't want to run into feeling like you're stigmatizing against one or telling them that they shouldn't. I've had this question before, shouldn't have children because they struggle with this abuse, because many of them do change their lives after they have kids.
And if I could just add to that quickly.
We would like to move on.
Okay. It's
Write it down, and there are many aspects of our case. We will be able to address your question. So please write it down on the index, and possibly we will address your question.
the family planning aspect for these patients. You'll find that they have pregnancy after pregnancy, striving to keep one of their children. So if we can keep families together, that is the family planning that seems to be the most effective.
So the really good news is Dr. Polsky is going to talk about many of these issues. So there'll also be a Q&A period briefly after his talk. So thank you for your attention. I'm Kathy Hoke. You'll be seeing me later on a panel, but I have the distinct pleasure of introducing Dr. Larry Polsky, who he said keep it short. And if I was to do so, I would just say he is an amazing friend of mine, but I'm also really lucky that he's a colleague. He is the health officer for Calvert County, Maryland, which is on the in southern Maryland, if you don't know, and he has been there for 7 years, which seems crazy because it seems like yesterday, but it also seems like forever. And I love that if you read the bio that's in your packet, it lists some of the responsibilities as health officer, and then it says, among other duties. We all have that in our job descriptions, but for him, it's like everything. Everything else falls on his shoulders. 25 years practicing as an obstetrician. The other day I was doing a presentation in Calvert County, and he came up to let me know he was apologizing he had to leave because one of his patients was getting out of jail and he needed to meet her to make sure she was getting the care that she needed. As if he needed to apologize to me for leaving for that reason. But that just gives you a little bit of a snippet into who this man really is. So there's a formal bio in the packet, but that's who you're about to hear from today.
Thanks, Kathy, and thanks for the invitation today. I went to medical school here. My first surgical rotation was in shock trauma, rocking some pretty hot pink scrubs. So it's good to be home again. And this picture is part of our group therapy. So I'll get into more detail about our program. But one of the aspects we have as a group is only for pregnant and postpartum women, and that is in part to decrease the stigma. I almost hate to use that word. Once a month, our group therapy is a cooking class. So some of our participants, there were others who didn't feel comfortable being in the picture, so there are more women who are part of the group, and also a few of our staff. Bonnie, who's our dietitian, is standing to my right. I was going to start off the presentation just with a brief vignette. Earlier this year, we received a call from a social worker at Anne Arundel Medical Center. That's Anne Arundel's just the county to our north, about a 25-year-old woman who I'll refer to as Bree, who was status post motor vehicle accident with a newly diagnosed pregnancy, likely in late first trimester, and a tox screen positive for fentanyl, cocaine, PCP, and marijuana. Although we were told she was a Calvert resident, we later found out that Bree was homeless and had given the hospital staff an address of a relative who lived in Calvert. Bree told us that her mother had been a heavy cocaine user and abandoned the family when she was 6 months old. Her father was the leader of the local Hells Angels group, and I'm not making this up. We have social workers who work with our prison population and verified every bit of her story. As a child, she was shuttled between her father's home and other relatives. She first remembered being sexually abused by both men and women at age 5. When she was 8, her father went to federal prison. She continued to be sent back and forth from relative to relative, and around that time, she was introduced to alcohol and cigarettes. Again, this is at age 8. Other drugs soon followed as she approached adolescence, and when she became a teenager, she was gang raped. She subsequently attempted suicide. And over the past 5 years, she had been in residential substance use treatment 6 times. She'd been diagnosed at various points with major depressive disorder, bipolar, various personality disorders, PTSD. She also had a lengthy arrest record and served several stints in jail. And the father of her baby was an active user who was also a drug dealer. Now, I'm not saying this to shock you. For everyone who works with this population, you encounter at least some aspects of this on a regular basis. I'm bringing this up because in rural areas, the depth of pathology, the psychosocial aspects are just as bad as in big cities. The only difference is we don't have the resources to deal with these things. So I'm not going to go through all this on the slide. I just want to touch on one thing. Dr. Mark, when she was in here, mentioned that just detoxing women and doing behavioral therapy is insufficient. So studies have shown that over 75% of women who are not offered medication-assisted therapy will relapse during their pregnancy. So particular issues in rural medicine. When we started our program, which I'll go more into detail in a few minutes, in 2014, there were only 2 physicians in our county who prescribed buprenorphine at all, and both of them refused to take pregnant women as part of their practice. So we had no access to buprenorphine for pregnant women at that point. We also have a general lack of behavioral health care, both mental health and substance use in rural areas in general. Every rural county in Maryland, except for one, I think it's Talbot County, is a federally designated mental health provider shortage area. There are no maternal fetal medicine specialists in any rural jurisdiction in Maryland, which means that the local OBs feel way uncomfortable treating women with these kind of problems, and we have no NICUs. So that picture is our nursery in Calvert's one and only hospital. That is not a place you want to be taking care of a sick baby. So I know Dr. Mark had to step out. I will disagree with her politely and say that in rural areas, NAS is a big problem because when your baby goes into withdrawal, that means your baby's getting shipped out. And that means if you just had a C-section, you're getting separated from your baby. And that means if you have 2 other children at home, you have to choose who you want to stay with. So in an urban area, I wouldn't disagree with her that NAS is not the worst thing, but in rural areas, it takes on a whole new dimension. We also have very limited public transportation. So if you're going to intensive outpatient treatment 3 times a week and IOP ends at 8 or 9 p.m., you can get a bus there, but there's no bus to come home. And everybody knows everybody. I grew up in Baltimore. I go to the supermarket. I didn't know anybody there. I go in the supermarket back home, and I recognize a lot of people. And so when a pregnant woman goes into an OB office or she goes into labor and delivery, it's a reasonable chance that she knows somebody that either she's related to or she went to high school with who's on staff. And her talking about her problem is a much different thing than somebody who goes in basically anonymously to a big city hospital. So these were touched on before, mostly during Dr. Mark's presentation. These are, I would say, pretty much universal. I don't care if you're rural or in the city. Almost every pregnancy is unintended, and I'll touch on contraception a little bit. When the run-up to the start of our program, we went back and contacted as many women as we could over the previous year who had been identified as substance using when they delivered their baby at Calvert. and none of them, 0, were using contraception. These were generally 3 to 6 months post. They would say over and over again that they could not remember anybody talking to them about contraception in the hospital, and they did not show up for their 6-week visit, and I'll get back to that in a moment. And then all the complex social problems, poverty, again, lack of transportation, homelessness or transient homelessness, arrests, domestic violence, intimate partner violence, and their partners almost always have some history, either active or in the past, of drug use, and that lends to its own issues. Almost every patient smokes, and as Dr. Mark mentioned, the biggest fear of coming in for care is that Child Protective Services is going to take their babies away. So here's your mental break for a moment. I was fortunate enough to go to the Galapagos over the summer, so I'm doing a maternal child theme. In the upper left is the mama humpback whale, and in the lower right is the newborn calf's head popping up out of the water. So here in a nutshell is our program. When we actually work with people from other jurisdictions, we spend hours going through different facets. I don't have hours to go through. I will highlight just a few things on there. I think the most essential was to collaborate with local obstetricians, labor and delivery nurses, and pediatricians. And when we started our program, we had patients literally coming in tears, the way they were treated in the OB office. And in labor and delivery, the nurses would say things in front of them, deliberately to them, that were they were being treated like human garbage. I would say it took a solid 2 years of working with our local staff for them to actually value what we were trying to do. And now, when somebody comes into our local OB offices, they do universal questionnaire screening and universal toxicology screening at first visit. When they identify somebody, they call us and actually ask us to, we're across the street from the OB practice. Actually, we walk over and start to work with that woman while she's there, hoping to make sure that we engage her in care. The core of our program is our nurse case manager, and Kathy's sitting over there with me today. We intentionally did not go the behavioral health route, so no offense to any behavioral health people in the audience, but these women are about as hardcore users you're going to get. I know our stereotypical is a junkie in the back alley, but anybody who knows they're pregnant and they're still using, that is drug dependence. Almost all these women have been through multiple attempts at rehab. Behavioral health just ain't working for them. And the way that we connect, the way that we form that trust relationship is through their OB care. So Kathy worked for a few years in our local OB office. Again, I have a clinical OB background. We talked to them about their baby in a way that an obstetrician or an OB nurse would talk to them about their babies. That's what they're interested in. Not interested in how they're going to get behavioral health care. They're interested in how they're going to keep their baby safe. And then once we establish that trust, we build from there. Our entire program was started through a community health resources grant for a whopping $70,000 a year, and we've continued to mushroom out. By year 2, we had universal access to Subutex Suboxone for our patients. And we really push emotional trauma and intimate partner violence services. We do as much as we can at the health department. This is not a population where you can tell them to go over here for something, go over there for something. If you're not providing it there on site, they're probably not going to get there. So Tuesday is our day, and today's Tuesday. So Kathy and I are missing everything today. And supplemental transportation services, which we use some of our funding for that. And then over the years, we've added in peer support, and actually you'll hear from our peer support person through a little video, dietitian services, and jail. We've worked with the jail staff, and we have an expungement clinic that we work with. So outcomes, we don't have a lot of specialists in rural areas, but we know how to count. So national stats for women who are opioid dependent, about a quarter of their babies will be low birth weight. We've cut that by 40%. And if you take a look at illicit substance use, we've cut that by about tenfold. So we still do have some women who are using off the street when they deliver, but only about 7%. And I will say the NAS, that's actually skewed a little bit high. The first few years we were doing this, the pediatricians in our little dinky nursery were scared of these babies, and they would ship them out the first time they sneezed. So the last couple of years, actually, our NAS rate for Subutex has dropped. And then getting to contraception, again, I think this is the one shame that we should all have, that reliable contraception for this population has been completely neglected. And I hope I'm wrong, but I'm guessing this is the only presentation you'll hear today where anybody mentions contraception. So two other stats we look at. One is 7 or more prenatal visits. I will admit that was an arbitrary decision on my part when we started the program as to what we would consider successful. But I would argue that in 7 visits, you can screen adequately for diagnosable congenital problems, you can identify gestational diabetes, and you can monitor reasonably well for preeclampsia. Everything else is window dressing. And 82% of our patients have had at least 7 visits, and using reliable contraception. And for us, that ain't condoms, because that's not reliable, and that's not Depo, because after you give them that first shot in the hospital, they're not coming back. We have somebody right now who has a 6-month-old at home. She got a shot of Depo before she left the hospital, and now she's pregnant with twins. And that was not desired, and that is a mess for her. So reliable for us is Nexplanon, an IUD, or Tubal. So I'm going to take a moment just to read through this, because I think it's important, especially for all the people who do social work out there. And it was touched on before that you can't neglect women after they deliver. So this is from an epidemiologist who works at HHS. So the greatest impact of perinatal illicit substance use on children may be the increased postnatal risk of neglect and maltreatment, foster care placement, and other disruptions in the home environment. These factors have much stronger effects on cognitive and behavioral outcomes than fetal drug exposure. And as an obstetrician, I would not argue with that. I would say that also postpartum is a new opportunity for patients who struggle with their sobriety during pregnancy. We've had women who they just could not completely stop, or they could stop for a week or 2 at a time. But once they held their baby, something just tripped in their brain, and they were able to stick with their recovery efforts. If you kind of write them off and just focus on the baby after that, you miss that opportunity. So going really quickly back, we see our patients, they generally stay 4 days in the hospital because of the subs that they're on. Babies are been watched. We see every one of them before they leave the hospital. We've made a few field trips up to Baltimore and Anne Arundel and other places if our patients deliver somewhere up north. We also see them back 10 days postpartum, and both at that hospital visit and the 10-day, it's to look for postpartum depression and other early signs that they're struggling, make sure that they have a safe roof over their head. It's also an opportunity for smoking cessation, parenting classes, contraception, WIC and DSS, and transportation issues when it comes to their newborn. So we started our program in late FY14. FY15, we did not have much in the way of MAT access. So this is the number of children who were placed in foster care as a result of substance use. They used to call it substance abuse back in the day. And you can see the dramatic drop-off once we had MAT added in, and our program really started to gain a bit of momentum. So we had an over 75% reduction within 2 years of children being placed in foster care. And I'm going to take a really quick little break here. So community outreach. We have a second arm to our little program, and that's to go to the 2 residential treatment programs in Southern Maryland. One's in Calvert, and the other is across the bridge at the border of St. Mary's and Charles County. So we send nurses out to do STI education and contraception counseling. We've also, just to touch on the sensitivities or not so sensitivities of contraception, we shouldn't treat women in these circumstances like they're fragile little eggs. You got to gain trust. You got to make them understand that you're valuing them as human beings and you care about them. There shouldn't be a concern that contraception is somehow going to make it look like a eugenics program. Neglecting contraception is doing them a disservice. So every additional baby increases financial difficulties, it increases risk of intimate partner violence, and other stresses that jeopardize the recovery efforts. If somebody wants to get pregnant, that's fine, and actually our stress is for Nexplanon and IUDs, so it's completely reversible. We do have patients that are on their 4th, 5th, 6th baby and they want to get their tubes tied. We're not going to stop them from doing that. But the vast majority of what we talk about really has to do with reversible. So this is a letter, I'm going to only read part of it, from one of the women who was in residential treatment program outside of Calvert. And she writes, I'm not sure what method, but I want the one that goes in the arm, not the shot, and I would forget the pills. I heard you take short-term girls, that's their slang for people in the 28-day program, to Calvert, and you're taking some soon. Can I please go as well? I really desperately need to get on birth control. I cannot afford to get pregnant or an abortion. And she writes parenthetically, I will relapse if I get an abortion, so please take me. So in our outreach program, we've educated over 3,000 people, and that includes both women and men. We've identified 50 people with hepatitis, a couple with syphilis, and one with HIV. And now, so the slides had to go in a few weeks ago, I think we're up to 304 LARC placed. We also do smoking cessation services there. It shouldn't be about the money, but it's always about the money, right? So we would conservatively estimate that in our now 5+ years of our program that we've saved the state close to $10 million off of about $370,000 in grants. And I will say that the numbers are all over the place as far as trying to calculate this stuff. You're not going to find any two studies that give the same cost of a baby in a NICU or an unintended pregnancy for someone who is currently substance using. So don't get too caught up in the numbers. In the slides, there are 2 additional that show the methodology we used and the numbers we used. So the screaming baby blue-footed booby means I'm happy to answer questions either now or during break.
The video should be ready now.
Oh, video's ready. All right.
Yes.
I was struggling with my addiction and my mental health using heroin and pills. I was really underweight. Mentally, I was all messed up, constantly crying, struggling even to hold down a job. I just felt stuck. What pushed me to get help was me being pregnant. I didn't want to lose my kid.
Patients have oftentimes very chaotic lives. We needed to coordinate services and sort of fuse OB care with mental health and substance use care, and also with social supports.
I started off with meeting with Dr. Polsky, and then we had to do weekly groups. Here, I feel like people actually cared. If I ever had an issue with my medication, Dr. Polsky was always available for me to call, and I started to gain weight. I started to look healthy. The longer I was clean, the happier I was getting.
We also realized that in order to sustain recovery, that people need meaningful, purposeful aspects of their life.
Normally, in Calvert, if you need some type of specialist or anything, you have to drive at least 40-45 minutes. So it's nice having a program that's so beneficial down here right in the county. If you're not out there getting high, then you're not committing crimes to get your next fixed.
The way that the healthcare system is set up for services like case management, there's no mechanism to be able to bill. In order to provide those sorts of services, the only way to be able to hire staff is to qualify for grants.
I could have lost my son either by miscarriage or to the state. I could have overdosed and died. A lot of stuff could have gone really wrong. I'm really thankful that I was able to participate in this program, and it helped me so much so I can be a mom for my son.
Anybody has questions, please, for Dr. Polsky?
So, yes, and then. I don't know of any program that works quite like ours. I know Hartford has now created a program that does a fair amount of what we do. But I will say that in stinking little Calvert County, if we can do this, that it's something that really should be replicable pretty much anywhere.
I had the same question. I'm here from Baltimore City Health Department, and I know there's a CAP program at Bayview, so I was trying to ask if anybody here can tell me if this model has been initiated to their program or they're following something similar, because a lot of STIs and opioid use comes out of the pregnant moms when they go for delivery here, and I get that phone call. So I was just asking the similar to the Anne Arundel County.
Yep. We've talked to a lot of people. I've presented this at state conferences. We've had people from Behavioral Health Administration and the state maternal child division come down and take a look at our program in action. I'm not sure why it's such a struggle to get these kind of programs replicated at other places.
Thank you. Dr. Millian from the CAP program in Baltimore will be here to address some of those questions.
All right, thank you.
Okay. And thank you very much, Dr. Polsky. And I can understand your deep connection to the women